Now we're recording. Okay, so good morning, everybody. Welcome back for day two. Dorothy and I are excited to circle back from yesterday. We're going to spend the first probably 15 minutes or so talking about any questions you guys might have had that surfaced from yesterday's session. I know we covered a lot of ground with our risk methodology, a lot of information to absorb there. And then anything from the reports, report builder, any other questions maybe we didn't cover yesterday that you all want to cover. I know Tennille had asked about some ways to manipulate the case profile detail reports, and I can show you that this morning if you guys would like.
Yes.
Okay, anything else burning? Comments, questions?
So I can keep going.
Sure. All right. Well, I'm gonna let me minimize the slides quick here. And I'm gonna go into the tool. And let me make it a little bit bigger for you all. Okay. So what I'm going to do is I'm going to actually run a case profile report. And I'm just going to choose a low number. I'm just going to, because we're just going to choose a small volume. And I want to get into a case profile and show you how we can manipulate that, okay? I'm not going to add any restrictions. This is just pulling a random case so I can get to that case profile detail and show you all how you can use that add, arrange, remove columns function, and then send that to Excel. So you have a smaller data set to work with. Because if any of you have ever drilled into a case profile, you know that there's just all that information in kind of a grid format. It's a lot to sort through and it's busy. Okay. So what you're seeing here is a case profile. Again, this is case one of the 10 that I did in my poll. And again, you can see all the different data parameters that are coming in. This is what's coming to us from your monthly data submissions at the encounter level. So every encounter has all of these data points included here. Using this add, remove columns feature, we can go in and remove from this columns and report section over here that I'm circling on the right-hand side. We can go ahead and remove any of those data elements that we want. Okay, to make our case profile much more manageable. So, for example, I'm going to scroll down to the bottom and let's just take like a random group of things off. I'm going to remove the ICD-10 procedure and diagnosis codes, which will take a bulk out. Again, not that you would want to do this, but just showing you the functionality of what you can and how you can remove these things. So everything that's highlighted now that's currently in the report, I'm going to click this middle button, remove from report. And then I'm going to click OK. And then it's going to make that just a little bit shorter, right? Now we are at case 2 of 10. So we've made that case profile a lot shorter. Up at the very top of the page is where you can find your Excel button, and then you can send this case level detail over into Excel. It does open in a new document in your browser, so you'll see down here I'm finding the document. And then within Excel, you'll see now that I have far fewer data elements to sort through. I think, yeah, much cleaner. Much cleaner. I mean, there's still a lot of data elements there that I've left in, but we're only going over to column BC as a column to, however many rows. Yes.
I'm still trying to figure this out. So if I would have done that and put it in Excel to begin with, I would just have.
You would have had everything. Yes.
So I could do it that way.
You can
whatever I did.
Yeah, however you prefer, right? If you're an Excel whiz and you like to just run it right to Excel and then eliminate the columns you don't need out of Excel the first time, you can do it that way too. This is just kind of a workaround within the tool to, yeah. lot less noisy.
And then you can save the layout too.
Yeah.
Yeah, that's what I was gonna say. So if you, because you can always add stuff back in, right? So if we go to that add remove column where you were at, and we get, so, you know, typically we would, you know, not want a lot of those things, but we would want, you know, dates or diagnosis, whatever. We can do that. And then you can save that. So every other report that you do will automatically look like that.
Yes.
Yeah.
So you'll save it, but then you'll also want to set it as your default if that's what you want to open each time.
Okay.
So like I can save this layout and just say OU test 2. I'm just using, you know, examples, but you could call it, you know, case profile modified or whatever naming convention you want to use, and hit save. And then now it's there in my layout options. So I have a Vizient default at one point. So there is a column that's not available by default for your risk model groups. So you can add that column in. So I did that as a customized layout so I could see what risk model group each case encounter had assigned. But then here's my OU test 2. I can choose that, and then I can say set as default layout. And then every time I run a drill down from a case profile, it will have that there, that default.
What if you were just running a general patient outcomes report and you know, it comes up and has your numbers and then you drill down to your patient? Will it go to this layout?
Yes.
Okay.
Yes, I've tested that. So it's your layout is tied to the report type. So a drill down into detail, case level detail will have that layout. So hopefully that helps a little bit with your case details. I go back to Vizient default layout. Okay. And again, you can always change your default layout back. If you decide you don't want that default layout, you can just choose from those that you've created and the Vizient default as well.
And then one of the questions in the chat was, can these save layouts be shared with other people?
Yeah.
They
There's an
can?
option there.
Is there? Okay. That one I've not been asked before, so that, no, that's real nice. Yeah, I exited out, sorry. I was gonna go to set my preferences because you can do some things in set my preferences too.
Yeah, but I think this one there, that was in that, they're all kind of the same
Yeah, that would be a good.
format.
Share layout.
Mhm.
Yeah. So the Vizient default is grayed out, but let's click one that I've created. And then now it's green highlighted so I can share that layout. So clicking a share layout, it looks just like it does when you do a share report. You have your option to select users. So I see every hospital because I can share with any hospital, but you would all just see your own. Yep, your own folks. Good, thank you. That's a, see, 4 years, I still learn something every day too, right? We can share a layout, so we can create it, customize it, and share it.
So I also thought select individuals. They just type in their name.
Yeah, so, yeah. So if you've ever done a share, like share report or share layout. So again, I have all the hospitals as an employee, so yeah. So we go to OU. It should populate your users. There we go. Should start seeing, there's Bobby, they're alphabetized by first name. There's Tennille. And then you just follow the kind of the path on the page and then you'll hit share.
And everyone there has case profile access.
Yes, yes.
All right. Any other questions from yesterday, or anybody want to see anything that will help you with your workflows with using CDB? Right. Then I think we'll go ahead and start with readmissions. Everybody's favorite topic, right? We have a love-hate relationship with readmissions. So this presentation today is titled Readmissions, Revisits, and Excess Days Reporting. Vizient has some templates available for you that will allow you to look at those excess days, or what we often hear called EDAC, from our CMS regulatory stuff, those EDAC metrics. And so we're going to talk through some slides this morning. I'm going to try not to just talk the whole time. Our goal is to get you back in the tool and run some scenario reports for readmissions, but it's really helpful to level set and get kind of some of that fundamental methodology around Vizient's methods for readmissions. So a couple things I just want to share on this slide. We currently track 30-day readmissions only. So within the tool, when the tool is mining and searching for matching patient record numbers to look for, was there a readmission? It's only doing that up to 30 days. We have gotten asks because I know there are some agencies outside of CMS that are starting to look at things like 90-day readmissions. Our development team is still, looking into the feasibility of that, but as of right now, it's 30-day. And that includes both for your individual hospital and if you ever run a system-wide report for readmissions as well. The 30-day calculation, so it seems simple, but we always like to give the definition. So it's basically your discharge date of your index encounter minus your admit date. So that's how we're calculating the within the 30 days. We refer to that first admission as the index. So you'll often refer to us, call that an index admission, not to be confused with our mortality index and our length of stay index, but an index visit or a first visit, okay? And then the readmission encounter is, again, that patient returning within those 30 days from that index visit. And then, as I mentioned yesterday, we refer to these as pairs, okay? So whenever you have an index and a revisit, that is a pair. And so as you see in that orange box circled, so what happens if there's a third visit? That actually then becomes another pair. So that second readmission also now becomes the index for yet that third visit. So you have two readmission pairs, so to speak. We like to show this kind of in a calendar form if you're a visual learner. So here's an example of a patient came 3 different times. In the purple, they were admitted on the 6th of the month, discharged on the 10th. They came back again on the 17th and were discharged on the 19th. So the purple and yellow is considered a readmit pair in that 30 days. But then when the patient came back again on the 28th of the month and was discharged on the 30th, that's now a third visit, but this is the index to this yellow 17 through 19 visit is now the index for that yet third visit. So we've got 2 different pairs of readmissions.
So it's essentially the second admission clock.
Yes, so it can restart the clock for the 30 days. So if the patient came, a 4th time, it would capture within this green, so yes, it's almost like a rolling, it restarts the 30 days, to your point. Okay, so we are going to get into the tool, but let me just make this a little larger for you all. Within Report Builder, there are 3 actually places that you can run reports for readmissions. So in your drop-down menu under I want to look at, you'll see an option for readmission reporting. You'll see an option for system readmission reporting, and then you'll see the readmission case profiles. And again, those are, rather than running a report and drilling in, you can just run your readmission case profiles. And once you click on that report type, you have some options. You can run them as pairs. So you can say, I want to see my pairs together. And that's really nice when you send to Excel, you'll see the index visit and the subsequent visit right there together in 2 line items. So just wanted to point that out.
Will it do it for all pairs?
Pair, you're saying? Pairs. No worries. Yeah, so this visual shows you that. So if I've chosen, I want to look at a readmission case profile, you'll see the option. So you can say, I want to see both cases in the pair. I just want to see the first case in the pair, or I just want to see the readmit case. So just some options there for you, the availability to look at those different options. And then again, you can choose up to the number of case profiles you'd like to look at. A lot of times this is kind of more of like a spot check way of looking at case profiles versus getting an outcome report in your readmissions and drilling it. So within your standard restriction section, when you choose a readmissions report, you will have 3 additional options for your standard restrictions. That's what's highlighted in this orange box here. And again, let me just make this slide a little bit larger. So you'll see those 3 options. The first being the readmission algorithm for CMS. This is taking into account the CMS planned and unplanned logic. Okay, so Vizient was able to source the CMS algorithm to look at planned versus unplanned. Now, we can't recreate it entirely exactly, and there I've got some slides here that'll explain that to you. The way CMS is able to get claims data, they have much more specific data around readmissions that Vizient isn't able to replicate based on the data coming into us. So, so we get as close as we can to replicating those CMS metrics, but using this unplanned algorithm for those, you know, planned versus unplanned returns to the hospital is where you can capture that. Again, the radio dial, you can look at planned only revisits, unplanned only, or consider all and look at both planned and unplanned. Readmission type. This is a Vizient term. So prior to having the CMS algorithm, we were helping our members look at, was the patient coming back for a related only visit or an unrelated visit? And these are defined in our learning center. You'll see we have a readmissions document that explains these flags to know what readmission related type is. And I have a slide that talks about that as well. And then the last section are those readmission flags. These are exclusion criteria that you can apply. So it gets, the logic is always a little wonky for me, but so when you check the box, that means you're excluding those types of cases. So check mark means exclusion, and you can exclude them from your numerator or your denominator, as you can see on those lines. So leaving them unchecked would mean you're including them. Checked is excluding. Any questions at all about that one? Alrighty. So these related readmissions, as I mentioned, so when you choose the radio button for related only, so Vizient's definition for this is that encounters are considered related if they have the same MSDRG for the visits, if they have the same principal diagnosis or procedure, or if they're have the same ARC clinical classification software, CCS category. We leverage that information in the tool as well if you use CCS. So those would be considered related. And then there's also the caveat, or if the principal diagnosis of the readmission indicates a complication of care. And again, those are all based on ICD-10 codes. Those are all defined in our learning center. But so if maybe it's a surgical complication and that's captured in that revisit in the coding, that would be considered a related return by the Vizient definitions. Again, we have those readmit flags. So these are those different check marks. We can apply those to either the index or the readmit case. And the flags are checked by default. So all those check boxes when you open a readmissions report are going to be standardly checked by default. But if you want to uncheck anything to include those, you can. You have that option. All right, so let's talk a little bit about in the advanced restrictions section. So if you populate an advanced filter, so say we want to look at this principal diagnosis, these ICD-10 codes here. If you look over that very next column where I've got my little mouse here, you can apply that to either the index, the readmit, or both. So you have the ability, again, to get really granular in your queries to say, I want to look at patients who were in our hospital with an index visit of COVID and came back with heart failure. I'm trying to think of something clinically relevant, but so you could then populate your diagnosis code of heart failure and then say apply to the readmit. So you can really start to get granular with how you look at your populations in these report types. And again, this is a reference slide that it describes that. So apply to the index, apply to the readmit, or apply to both, and it shows you those definitions. So let's look at, this is an example looking at acute myocardial infarction. If we only applied it to the index on the first encounter, you'll see our 30-day readmit cases, we had a volume of 13. And then if we applied it to the readmit cases, we had a volume of 4. If we apply it to both, we then have a readmit of 1. So just kind of showing you the differences of when you know, how you can apply it to different ones. Well, I have this slide up. I do want to point out too, this is a standard readmissions report output. So moving from left to right in the report details. So you have your total volume of cases, and then you have what we call our readmit rate denominator cases. This is when we apply those exclusion criteria, you're whittling down your case volume to your exclusions. So this is the denominator that's used to calculate the rate for the percentages. Makes sense. We also give you length of stay information in a report output, because again, a lot of times we want to correlate length of stay with readmits, right? Did we have a really low length of stay, and is that what's contributing to our readmission? So giving you length of stay information there as well. The 30-day readmit case volume and percent, and then the 14 and 7. These are all a roll up. So your 7-day cases are the same patients in your 14-day. So of those 10, 7 had a 7-day, and then that is a roll up into your 30-day. So these 13 are all a roll up of, these are not separated out individually, if that makes sense to you all. And again, we have, this is really more for a resource. It's not for you all to read. It's sort of an eye chart today, but it describes each of those column outputs, and it has the definitions there for you. So for example, the readmit rate denominator cases are all those eligible patients for a 30-day readmit after any clinical flags or those exclusions were checked in your standard.
So in the 30-day, you also get the 7, 14 on all of them.
Yes, yes. If you drilled into those 30-day cases, you would see those that had the 14 and the 7. And in the case profile, in the readmit case profiles, you'll see days to readmit. That's a field value. All right, let's talk quick about system readmissions. So this was fairly new in the last couple of years that Vizient created, and this was in response to hospital systems that have multiple hospitals. So with Vizient's methodology, as I talked about earlier, not only do we capture the 30-day, but we can only capture for your facility, right? Based on the patient's MRN and the hospital Medicare ID, so the patient leaving your hospital, coming back to your hospital. However, if you're part of a hospital system, if you have multiple hospitals within your system and you're submitting a data element called the EMPI, which is also known as the Enterprise Master Patient Index. Other hospitals call it like a URN, a universal record number. Vizient's using the EMPI term, but that is a patient identifier that will allow us to track admissions and readmissions between your system hospitals. So like we were talking yesterday, Tennille, if a patient maybe presented here for surgery or some magnitude, but then they live out closer by Edmond and return to the hospital in 30 days at Edmond, it would get captured in this system level reporting. Okay. Trying to think of any other, relevant examples, but it would basically be hospital, anything within your system that you could track. Mm-hmm. When we look at the differences between the two, this is just kind of differentiating. So again, our readmission report is looking just a singular hospital. Your system readmission will look at both. When you run a case profile, you can actually see the Medicare ID number for the hospital. So you can see, oh, they went OU Med Center to Edmond, Edmond to OU, et cetera. So you'd be able to see that data set within the case profile. Again, this third line is basically indicating that. So the index and the readmission hospital Medicare ID number are going to be the same, whereas in the systems readmission, they may be different if they're going between the two facilities. Here's something that we do want to give as a caveat. This very last thing under system readmissions. A lot of times we'll get the question, well, can I compare my system readmissions, say, to Barnes-Jewish system readmissions? And we discourage that only because systems are so varied geographically. They just have different makeup. And so from a benchmarking perspective, to try to compare your system readmissions to another's, it's really more for your internal processes to look at how patients are moving between your own hospitals. That makes sense. All right, so where do we get these system admissions? This is again, a drop-down menu option. As I showed you earlier, under your I want to look at reports, you'll see the system readmission option. So that's where you would find your system readmission reporting. And then you'll see a new option under your advanced field under patient identifiers. Now we're looking for that EMPI, which is again, that universal number that are on patient records.
So, I would think this is what we need to be using for the most part. Is that what your thought is, or am I thinking?
Not necessarily in the most part, because looking at a lot of our metrics that we look at that are presented out there are comparing them back to our CMS, as our root cause hospital compare. So I wouldn't say necessarily the most part, but for looking at PI project stuff, yes. I would
Well, I'm
think,
just thinking readmissions, it doesn't matter where they come back. I mean, because we do get patients, even from children's, that have been seen at
right,
the adult hospital. They may not get admitted over there, they may get transferred over, but they're seen in ED. So
yeah, I think it's
Or
better.
trauma.
I think it's something that we probably have to use both.
My selections are drug visits on patient ID.
For EMPI or for,
Yeah, for any counter number, patient ID number.
EMPI is crossed out as well? Okay, and you selected a system readmissions report?
Yes, I did.
That's just what I was thinking. Is that under advanced or is that under?
It's a advanced restriction patient identifier.
Same.
EMPI is crossed out, okay.
Oh, wow. Did you guys click on OU medical system?
No.
No.
It didn't matter?
Doesn't matter.
Okay. Okay, all right. Let us investigate that. I know you guys are submitting it because I ran, in preparation for this presentation, I ran a case profile and saw EMPIs populating. So I know that that's happening.
Mine is actually, I can do it now, so make sure you did it under system and not focus.
I did it under system.
Focus hospitals.
So I did some admissions.
So you just go pick the system.
I did system readmission.
What time frame did you?
I just left it Q3 of 22.
You want me to show it? Let me get out of the slide back here.
Yeah, I
Yeah.
think that's probably the most helpful.
Yeah.
I have it under compare. That's not.
system readmission.
Yeah.
But I can't even choose a focus hospital.
So don't choose the hospital, go below that one and say focus hospital. system.
Yeah.
And then
So I'm in the tool. I'm going to choose a system readmissions report.
Yeah. There we go.
And then under focus hospital system, so go down one level from your focus hospital, go to focus hospital system and choose OU Health.
And make sure you're not under.
Or OU Med,
compare.
sorry.
It's better than it's a compare.
Yes, yes. Focus hospital system. It came up. Okay, good. Okay, great, great. And then under advanced restriction patient identifiers, you should see EMPI. And again, this would be how you would filter, if you want to filter for, a patient's EMPI and you want to, filter for that patient or several patients. Okay. Awesome. All righty. Again, this is just more of a resource slide to give you definitions for each of those report outputs. It's set up exactly the same as what you saw with a readmission report for a singular facility. So the definitions are all the same, right? Your 7, 14, 30 day are all roll-ups into one. You've got your cases and then your denominator cases for your rate based on those exclusions.
Can you go back one slide?
Yes, ma'am.
So this is your output. And if we were looking at, say, to see specifically how many of our cases were going between Edmonds and OU Medical Center, would it give us an individual row here on the top of the system? Or would we not see the facility until we did the drop?
You wouldn't see the facility till you did the drill down.
Into the-
Yeah, we do have a workaround. It's a little bit of a involved workaround. You can create a custom list using your individual facilities and save those as a custom list under your, is it under compare?
Yeah.
Under comparison. And then you would see them individually listed out in your report out too. Or you could drill into your cases, send it to Excel, and you'd see your Medicare IDs that way too. So both of those options give you the ability to look at where they originated on their index and where they were on their revisit.
Thank you.
We're on one.
Yes. But within the system, we have like
Like
a
a-
custom. done-
Yeah,
Okay.
they created created mock IDs. Even though you submit to Medicare and everything under one Medicare ID, for the purposes of CDV, we created different IDs for your hospitals. And that number is listed. If you choose Focus Hospital, you see that number. That's what's being used. All right, so now we're going to talk a little bit about non-inpatient readmissions reporting. We're a little more limited here. It's really basically looking at ED, but they're, definitely interested in looking at those patients that are coming into our ED frequently, looking at opportunities there. So what we're doing here is we're actually selecting the non-inpatient radio dial here. So we have a non-inpatient selection. And then in your I want to look at, the option here is the returns to the ED report and the returns to the ED case profiles. So those are your two non-inpatient readmission report types. When you select a returns to the ED in this non-inpatient population, you'll get another option here to select, and you can look at up to 5 numbers between 1 and 30 days. So in this example here, you'll see I have 1 day, 3, 5, 7, 15. You don't have to choose 5. It's just giving you the option to choose up to 5. And then your report output will have those each stratified. So patients that came back in those timeframes from ED to the ED. And again, these were ED visits that were discharged from the ED, never became an inpatient, because if they went ED to inpatient, they'd be in your inpatient population, of course.
And obviously it's going to be included or not.
So OBS is your non-inpatient population. So if they went ED to OBS, they would be included. If they were discharged from OBS and not admitted, they would be included in this returns to ED report.
Okay, can I ask another question? So
Yeah.
if they were inpatient discharged, but then returned to the ED, where are those people captured?
We're going to capture that. You just set me up really
Oh,
nice for the next. That would, like, did you plan that? Like, did we have a conversation before? Yep, we will be able to show you those too. So, all right. Any questions on this one? Again, just a nice little resource here to look at all the column details, but essentially looking at that ED visit only. Again, you have the case profile option, so we can do returns to the ED in a case profile. That's a report type. And then again, you have the option to show the number. This is kind of just more like a random spot check. This is, the utility of this is less than drilling into a report, right? Because what if you had more than 50 and you only selected 50 in your time frame? So this is kind of more of like a spot check look, is kind of the utility there. Both readmissions reporting. Here we go. So this is, again, this was Vizient's response to questions just like yours. And really, again, this is where we're going to get to those EDAC measures. So this is where we're going to start looking at some of that CMS stuff around, okay, patient was in our facility and then came back, either as an ED or an OBS or an inpatient. So what I want to show you here is when you're in the tool, whoops, didn't mean to do that. I was trying to make it larger. When you're in the tool, you'll see the radio dial for both. And when you select both, you'll notice in your I want to look at dropdown, you only have 3 options. Both reporting is really only about readmission reporting. Okay, so when we're combining the data sets of inpatient and non-inpatient, we're looking at those revisits or readmissions. There are 3 report types. The first is readmission by first admitter visit. The second is your readmission by the readmit visit. So it means your output is going to be based on that revisit. And then the very last one is the total revisits excess days. I will tell you, when you're using the both, the most common one you're going to want to choose from this menu in Builder is the third one. Okay, that's the most robust. The first two are really designed for, and I'm going to talk about this later this morning when we talk about our quality and accountability scorecard and those metrics in the scorecard. We have some very specific metrics around things like your patient came in for an outpatient procedure like an arthroscopy, and then came back into the facility with some sort of complication related to that. This first report I've got highlighted here, we have a template for that metric in the Q&A, and that will drive you to this report type. And it has very specific parameters set up to be able to look at that type of population. So I'm just going to put that out there as a caveat. When you go in and just select this as a report type, you're going to see some really, really wonky numbers, because what it's doing is it's saying, if you think about your non-inpatient data, and we have an encounter type of clinic and diagnostic testing. Okay, so if a patient was in your hospital and had an inpatient stay and then came back for a follow-up x-ray or a follow-up blood draw, this report would capture every encounter. So it's really not meaningful data unless you drill into those criteria and say, okay, we only want to look when that patient came into the ED, or, you know, so I'm just cautioning you here to really use this when you just see it as a template and not try to use it as its own standalone, because you're really going to see some really weird numbers. Does that make sense? Okay. And again, when we go into Q&A a little deeper this later this morning, I'll show you those examples. I think it's in one of our scenarios too, perhaps. How are we doing on time? Still okay. So again, this is just an example of that readmission by first visit. And you've got some different options there in your by variables. There are far fewer by variables in readmission reporting than there are in your patient outcomes, for sure. And then again, when you look at it by the revisit, you have some different options that you can choose for your variables and how you want to stratify the data out. This gives you a nice definition resource as well from the slides. Was there, I'm sorry, was there someone have a question? Yeah.
Gender, when that's good.
Yeah. Okay, so we're going to end with the most robust report, and there's a lot involved with this one. So total revisits, excess days. Again, this is a report type that's available to really help you look at that EDAC metric, or excess days in acute care. Again, just kind of level setting with Vizient's rationale for creating this. We all know, no one in the room is surprised that this is something that's involved with our inpatient quality reporting. It also impacts CMS stars. CMS stars rating looks at EDAC measures. So really want to make sure we're staying in tune with this. The beauty of Vizient is that, you know, yes, it's a couple months in arrears, but it's not like your CMS data where it's years in arrears. And so you really have the ability to track and trend. So we're including this excess days metric in our Q&A ranking. So when you go into the quality and accountability scorecard and use those templates, you're always going to come back to this total revisits excess days report. It's not a standard inpatient readmission report. It's going to be leveraging this total revisit excess days in the both section. Again, the criteria is going to be slightly different than CMS. We can't always exactly replicate what CMS methodologies are due to the limitations of how our data is coming in and based on what they're able to get from a claims perspective. Again, Dorothy mentioned yesterday when she talked about risk methodology, we don't risk adjust readmission. So we're not ever going to have, I shouldn't say not ever, currently our data science team is looking into possibilities of how we can give you predicted values. What are your expected values for rates? What we do leverage though is our risk adjusted length of stay to kind of get that excess days value, right? What would we expect that patient to be here for? So that's kind of baked into these excess days reports based on that logic of your expected length of stay. And then again, it is using that CMS planned radio button. So we do leverage the CMS planned and unplanned logic there. And again, this little caveat here, we have our Q&A methodology document that really kind of spells this out, and that's available within the Report Express. So this is going to allow you, to your question, look at your inpatient, your OBS, and your ED cases and any visits among those. It's going to give you your percentage of inpatient readmissions. So you'll get a rate, a 30-day rate out of this report. And then you'll get that calculation of those excess days. So number of days. Again, this is a portion of the quality and accountability study, and it's within that effectiveness domain. So broken down by service lines in the Q&A, and then you'll have those metrics within that domain. And then again, we have templates that you can mimic then and use those to track and trend this more frequently. Just going to make this larger here, and we're going to get into the tool with scenarios. But so when we have both selected, so again, our radio button of both, and that third option of total revisits, excess days. And again, these are all of the different stratas that we can break our data out by. So again, we can look by service line, we can look by admission source. So you can look at those patients maybe that came in from your SNFs, look at those that transferred in from other hospital facilities. The other functionality of this tool you'll see in the orange box over here. This tool, this report type, this template in the tool itself is hard-coded to only look by quarter. You can break it down to look within that quarter by discharge month, but you cannot go over here to your custom setting and choose a time frame of interest. It's designed specifically to mirror the Q&A scorecard, so we track and trend based on quarters. Now, again, you can use the discharge month by variable to break that quarter into the monthly views, but you can't create a customized monthly spread to look at for this report. And that's by design. Again, back to our standard restrictions. So this is a default setting. So I just want to point this out. When you open from the templates for Q&A using the excess days report, I want to show you what you're going to see. And this is also by design. So remember when I showed you a regular standard inpatient readmissions report, by default, all of these little boxes are checked for the exclusion criteria. When you're using an excess days, total revisits excess days report, Vizient already has this hard-coded to be the default for what we want it to do to mirror CMS logic. Okay, so that's another difference with this report type, is your default is already there set up to that you can manipulate them if you choose, but it's set up as the default that way. And so it's excluding from your numerator cases those that are coming in for a rehab visit, a dialysis, or those that have a mental disease or alcohol diagnosis for the revisit numerators. Any questions on that? So within the template section, so in your tool in the CDB, if you've never gone there, it's kind of a hidden gem. There's this over on the far right, the tab called Report Templates. And this is where you can find already pre-built, pre-populated reports with some criteria that you can use that template, send it over to Builder, populate your focus facility, populate the time frame you're interested in, but all the other criteria in the advanced restrictions is there for you. And so what we're showing here is under the quality and accountability scorecard, again, under that effectiveness domain is where you can run these, these readmission revisits excess days by those Q&A service lines. And again, showing you over here on the right is the way you send, if you've never used templates before, it's this little icon and that'll send that into Builder and have it all pre-populated for you. So this is an example. This is what the advanced restrictions look like when I've used that template and drove that template over. So we already have things pre-populated. So we're looking at cardiology service line, we're looking at the time period, and then it's eliminating some of those CCS diagnoses, again, based on CMS criteria. So you'll see principal CCS not, and so it's excluding some of those things, and then also excluding some of the discharge statuses. So let's talk about the output. This is really the most important thing that I want you guys to take away. So again, based on our pair logic. So we're still looking at pairing here. And so we always are starting with an index counter for inpatient, but then our revisit can be either inpatient or non-inpatient, and non-inpatient would be your ED or your OBS. Okay, so it's capturing basically all three of those criteria options. The excess days is actually the number of days of that revisit case. So that's the calculation for that EDAC measure. Like how many days was that patient here in acute care beyond their initial stay. So when you look at the output, again, you have your total index encounters column. You have the number of cases that came back as an inpatient. You have the number of cases that came back as an OBS, and you have the number that came back as an ED. These three values added up total your total number of revisits. Okay, so this is number of visits. And then those are all calculated into percentages then as well. So 187 out of 1,300 was a 13.9% house-wide readmission for inpatient. We look at the number of days of inpatient then as well. We look at the number of days and OBS. And so this whole second section here is where we start getting into our excess days calculation. And I think on a future slide, yeah, this is broken down a little bit further. So this first orange box is all of your revisit volumes and percentage of inpatient. And then this second section in the yellow box is all of your days calculation.
So can you look at like the opposite? Can you look at the index visit being ED and then the revisit being either hospitalization or another ED?
What I would do with that one is use that first report type option that I showed you. And then down in the advanced restrictions, you'll want to choose encounter type and then ED, encounter type ED, and apply to first visit.
Okay.
Yeah, so with some manipulation, you could do that as well. So maybe I wasn't answering your question if you, so this is looking purely inpatient to all the other settings. If you're looking at wanting to look at ED that came back to any of those, then you would use that first report type. Mm-hmm.
Yeah, no, those are two separate.
Mm-hmm. So in this example, again, we're looking at, so the number of days these patients were in the inpatient setting, the number of days in OBS, and the number of days in ED of all of those cases that came back. And then we calculate the total number of days. So these three data elements get a total. This expected inpatient day is based on, again, that expected length of stay off of the inpatient returns. Okay, so that's where we're getting that expected value. And then what we do is we take that expected days and the difference between total revisit days and expected to calculate your excess days metric. Okay, so that's what this column here is. And you'll see that it's negative. So this is actually an ideal situation, right? We had fewer excess days than were expected. So seeing a negative value there is actually ideal. And then we also do the calculation excess days per 100 index encounters, because I believe that's how CMS also displays that metric, is excess days per 100 index encounters. This slide is really busy. I don't think I want to really talk to it so much here. Again, it's more of a reference for you all to really understand, but it's basically explaining those same things I just shared with you, how we're calculating those excess days. We're adding up your observed readmits, your observed and your ED days, total those minus the expected, divided by the number of index admissions to get that average excess days per 100. So this is just kind of stepping you through the columns and the math that we do for that. And again, this is a similar slide, just showing you that breakdown, kind of using the math to look at the percentages. So how do we get this percentage of 15%? Well, it's your 75 revisit cases out of your 500 index encounters to get a 30-day rate of 15%. And then again, the same thing for your total number of revisits, your total number of revisit days, and then the excess based on the expected. So let's just go through a couple FAQs. So this kind of goes back to that functionality I was talking to you all about that it's hard coded to only look by quarter. So why don't I see discharges for the last month of the select quarter in the excess days report? So here's a perfect visual of that. So what this report has done, I chose quarter four of 2019. This is just dummy data example. But you see October, November, December, but you see in December, look at that total index encounter volume. It drops significantly, right? From 4,000 cases to only 58. The reason being is, again, this is hard coded to only look at quarters. So it's only capturing the index visits of anybody that had the potential to come back within those 30 days of when the report was run. Okay, so you kind of got to wrap your head around the logic there, but we're only capturing through December. So we really could only see revisits through the end of December. And so that's why that volume drops off so significantly, if that makes sense.
So would it be recommended to look at, if we're gonna look at these reports, to look at them by quarter, maybe pull like 2 quarters at a time?
Yes, you can. Just knowing that whatever the last month of the most current quarter is going to be truncated.
So what I usually do, I do discharge month and then I delete the last month.
Yeah, when you start socializing this data, you're going to get all these kinds of questions like, you know, why is our volume so different? But so we like to help prepare you for that.
Yeah, or just delete it.
Yes, true. All right, a little more on the CMS readmission algorithm. I don't want to get too in the weeds here, but so again, we're really looking to capture those unplanned readmissions within 30 days of discharge. Again, this is all based on CMS criteria. Those planned are not considered readmissions. We don't include all the CMS criteria. Again, there's just some specifics. I've said it numerous times this morning, but there's just some very specifics that we can't replicate. But you don't have to just use it. You can apply it to any population of interest that you're interested in. Again, the radio buttons, as I'm showing here, this is from a standard readmission. In that section, you can choose planned only, unplanned, or all. And again, the criteria this is based on the CMS definition. So if it's for bone marrow, kidney, or other organ transplant, if the patient is coming back for maintenance chemo or rehab, or a potentially planned procedure, and the principal discharge diagnosis is not an acute complication of care. This is a visual of that readmission. And again, the link to where we pull that from, that's directly from QualityNet. And you know, this is that CMS defined algorithm. Here are the things that aren't replicable. So I kept referencing this, but this is a really good slide. Again, if you do get asked this question by anyone. So Vizient cannot capture patients discharged and readmitted on the same day, whereas CMS can, right? We just see that as a singular, like a singular visit, but CMS is looking at that as you know, discharged and readmitted. We also cannot, so how do I explain this one? So Vizient gets payer data, right? We know from an encounter what the payer type was, but we have no way of knowing in that data submission how long they had that coverage. CMS knows how long the beneficiary had the coverage. So there are criteria that if they were only Part A in the first 12 months prior to the admission, but Vizient data has no way of knowing that. We just know that it was a payer type of Medicare. Okay. And then again, without at least 30 days post. So anything with a time constraint around payer type, Vizient can't capture that. Again, we don't do risk adjustment for predicted rates of readmissions. And then again, we cannot find your readmissions across hospitals outside of your OU health system, whereas CMS, because they're getting the claims, can see all of that data. And again, this is within our quality and accountability methodology document. We do have some report templates that we've created, that Vizient has created looking at CMS. So those disease-specific criteria. So let me make this slide just a little larger for you all. Again, your COPD, your acute myocardial infarction, your heart failure, pneumonia, total hip knee, CABG, and then your hospital-wide. So those exist within the report templates and have that criteria pre-built for you in there as well. We also have the excess days report. So that first template I showed you was a standard readmission, and this is the total revisit excess days. Okay, here's another thing that comes up quite a bit. When I use the templates, why are I not seeing results? Again, we want to make sure your payer mapping is correct. So we've found this happen from time to time when folks are using the templates that we're not getting any results, and we found out it was because the payer type for Medicare was not mapping to the correct. So that's where you're at. Okay. Okay. Yeah. And you're working with data intake folks to resubmit. Okay, perfect. All right, and then this is just again an example. We're going to talk more about the Q&A later this morning, but this is an example of the calculator and those metrics under the effectiveness domain, all your excess days metrics, your readmission metrics by Vizient Q&A service line, and then also kind of what that looks like in your overall scorecard in the effectiveness domain. Poll questions, we do that on our virtual training, but so a poll question, which of the following cannot be replicated in the CDB? Again, this is what we just covered, but it's that any of those time constraints. So if they were a beneficiary 12 months prior, 30 days post, and then readmissions across all hospitals, that all cannot be replicated in Vizient data. This restriction definition. So in our Learning Center, this is a screenshot of our Learning Center at the very bottom of the page. When you enter the CDB Learning Center, scroll down to the bottom. Under that first tab, Vizient Mapping and Definitions, over here on the right, under Vizient Definitions, CDB Clinical Flags. So these are where you'll find our readmission flags. So all those check boxes you saw for chemo, rehab, all the ICD-10 codes that define those are listed in this document. There's tabs for each of the report types for readmission reporting. All right, so now the fun part. We get to do some scenarios. It is 9:03. We don't have a break baked in right now, do we? We're doing that after this?
I'm sorry.
A break?
Yeah,
After
this.
Okay. All right, so I will, let's see. For the Zoom folks, because I'm on Zoom, I'm going to follow along in the tool. How's that sound?
Oh, I can do that, Jen.
Are you in Zoom?
Yeah.
Oh, okay. Cool.
No, I'm just make sure Hello, this is Dorothy. Can you hear me?
You're lighting up.
Oh, good. Good.
Yep, that comes up.
Okay. And let me share my screen. Here. Display that one. Oh, are you still?
Wow.
I don't know what happened there.
Yeah.
Let me stop sharing.
Star Wars.
You unplug, can you unplug yours, Jen?
Yeah.
Thank you. Display. All right. And now.
While she's setting that up, any outstanding questions about readmission reporting? Excess days.
No, I'm not sharing on the screen now. Okay. There you go. All right, you ready for our scenarios? Number one, your ortho department wants to know how many arthroscopy patients returned for any reason. You have generated an all-cause both type readmission report by first admit visit for your facility by using the Q&A effectiveness template for arthroscopy patients for the most calendar year and supply this to your leadership. So let's do that by going here to yours. And then, so once you're here, click on the report templates. and it's gonna take a long time.
Yeah, templates do take a while to load. That's by design. There's, yeah,
Yeah,
there's,
and you'll see that it's like spinning. Because it's like, there's like, I don't know, 700 templates there. All right, so now we should all be in on this. No?
Yes.
Okay.
Hey, can you hear
Good.
me? We can't see anything on Zoom.
You sure? All right, so we're now gonna go to the Q&A header.
Can you
Just,
hear me?
expand that, just click on the header and it will expand. And then as you can see, there are 3 versions or years of the Q&A. So click the most recent one. And then once you click on that,
Hello?
your cohort, which is the first one, Comprehensive Academic Medical Centers. And then the readmission template would be under the effectiveness domain. So click on that. And then when you scroll down, you'll find arthroscopy revisit.
Hey, Dorothy,
So
Dorothy,
as you can see here, you
can
can
anyone
look at the
hear me in
criteria
that
first,
room?
just to make sure. And
Hey,
then once you know
Dorothy?
this is what you want, you X that out. And then the icon here, the last icon on the right should be edit or modify. So
Hello?
open that template or open the template.
Hello?
Now this is important because as you can see, your focus hospital is not your focus hospital, right?
Right.
So this is an important step. Make sure that you change that.
Oh. They said they can't see anything.
Oh,
I'm sorry, yeah, I could minimize. Okay, thank you.
oh, I stopped sharing, that's
What
why.
happens when I
Sorry,
see that? There we go.
sorry.
So can you mind going back?
Yeah, let's go back to report templates. Right here. It's taking a while. All right, and then Q&A are quality and accountability. And 2022 and your cohort and the domain effectiveness. Scroll down and find arthroscopy revisits. Click on the edit or open template. And then change your focus hospital. All right. And we're gonna select, as you can see, it will also default to that time frame of the Q&A for 2022. So if you want to change that, you can do so at this point as well. Okay. And then we're not going to do hospital systems. We're not going to compare, right? We're just going to run this report. Are we all good? All right, so now let's run it using the tabular icon. And we're just going to try to understand the report output. So no benchmarks or comparison or anything like that. So this is the replicating the Q&A time period.
and before you ran it, you might have noticed in the advanced restrictions that was all pre-populated.
Oh,
So
yes.
all the CPT codes for arthroscopy are there, and you'll see it's going to apply it to the index. Your encounter type for index is going to capture your outpatient surgical suite, your, any environment where an arthroscopy would happen. That Vizient data should be included in the encounter. So all that's pre-populated for you. See it probably
Right
there.
here.
Encounter type, freestanding ambulatory surgery. So all that's pre-built.
All right. So now we have this report output. So we have 148 cases with arthroscopy, right, procedures. And then 148 is, that means that they're eligible for readmission, and only one came back. Right, and then so the rate is 0.68% for your readmit cases. And as you can see here, the encounter type already, like Jen mentioned, encounter type is already selected for you. The CPT codes, basically it's just the CPT codes are the ones that's very helpful here for the templates, because you don't have to. Yes. Mhm.
You need it.
Yeah, yeah, true. You use the templates that way too. Yeah.
Sometimes when those numbers is not.
You can copy paste.
Yeah.
Right.
And so here, you can copy from here, like for example, I don't know. And then if you want to add a restriction, something else, you can also do that. So here's the encounter. And then if you want to just look at, you know, sometimes you just want to look at, okay, let's see. I just want, you can uncheck this if you just want volumes, right? Want to uncheck that, and you just want inpatient. Oops.
Yeah.
Or no, delete, sorry. All right. No, it's not going to let me. But if you want to just look at the volumes, for example, if you want to just look at the inpatient mortality outcome, so you copy that, you delete this, and then you go back here, change it to inpatient, no, to non-inpatient. So again, CPT codes are just
You can't go back, like if I decided to change to a different quarter without rebuilding the whole thing, you've got to.
go back here on this screen.
The time.
You could change the time. frame,
Yeah.
With that one to the template.
Other things.
You can't go between report types. I think you can change any of those criteria at the bottom. You
Mhm.
could. Yeah, advanced restriction time frame, focus hospital. What Dorothy was trying to show you, she's trying to go back and do an inpatient report to do a patient outcome. It won't keep that criteria when you bounce between.
Yeah.
Yeah. It like gives you that little error message saying that, you know.
But this one, I just want to show you how to copy and paste the CPT codes. Hopefully this will work. Oops. Why is it core measures only? Non-inpatient. Right? Oh, never mind, it's right here. CPT codes. And then I think you're gonna, right here, right? Search.
Actually populate them there, not in
Right,
your
sorry.
search bar. Yeah.
Oh, and then let's see. And then right here. So if you click on this, if you just want to look at again, the patient outcomes report, this is what you'll do, just copying and pasting it on that box. And then if this is the report that you usually would use, I would suggest also saving this as your custom list. And that way you don't have to go to the quality and accountability, the template section, you don't have to go there. It's already custom. So like if you're interested in looking at the mortality data for your arthroscopy patients, you can do so this way.
So, and that will show you which previous.
Mhm.
Patient.
Yeah.
So length of stay,
No
no,
mortality.
yeah, usually if you're non-inpatient, yeah. So you can, that's what you can use for templates.
So could you do it by variable to show, to have the information come out that listed by the CPT codes?
Yeah.
That way you could easily see where your numbers are
You
Right.
can.
without doing the drill down piece.
You can. What I will say though, anytime you're in the tool and you segment by CPT or by diagnosis, the way the tool pulls data is it will also show those that you're interested in, but it shows any CPT codes that were also
So
on
there are,
record.
there'll be
So
duplicate.
while it's pulling cases of what you filtered for, so it's saying, I'm only showing you those that had these CPT codes, any other CPT codes on that record, when you stratify by CPT will be included there. So that is, something to keep in mind.
So what I did here, because you were interested, I wanted to show you, I did patient outcomes by CPT codes. And if you total it, it's going to be more than what your 140 something patients. All right. All right. So while that's running, never mind. So see here now are your CPT codes. And not only those arthroscopy patients, you can see the different procedures.
Well, it's only the arthroscopy.
Oh, I'm
patients,
sorry, yeah.
But it's other procedures those arthroscopy patients had.
Yes. So if you deleted this, if, for example, you did not have this advanced restriction, then yeah. Yes. All right. So I'm just showing you different types, things you can do now, because yesterday we were in a rush. So any questions in the first scenario? All right. Next one. You've been asked to review your inpatient oncology service line by your oncology director. Do we have that here? He or she would like to know the number of times patients were readmitted within the subservice line of leukemia and lymphoma. So he would like the data separated by those who were readmitted for related visits, unrelated visits, and all for the most recent year. And she would like to exclude those cases returning for chemotherapy. And this request will require 3 separate reports. Which grouping would you expect to have the most cases, and what was the total number of cases for related, unrelated, and all cases, as well as the 30-day readmission rate for each? All right, so we're gonna go back. Sorry?
No, I did not. You did read it though, and you approved.
I know, but it seems similar to.
All right, see how when I do this and when I try to select inpatient, it's telling me you can't switch because you filtered by CPT codes. Yeah, so all you have to do is delete this and then click OK. Or again, what you can do is click on Report Builder and it will refresh. Okay, so let's do that as well.
While that's loading, I'll just let everyone know. So Vizient data only leverages CPT in the outpatient population. Inpatient, we're looking at ICD-10 procedure codes. So you won't find CPT as an option in your inpatient population, just in your non-inpatient.
All right, I'm looking at what time period? Most recent year. Okay, so inpatient and then readmissions. Report in the I want to look at section. And do we need a bivariable? No. So we're just gonna click, leave the default. And then again, let's select the 4 quarters there. Quarter 3, 2022 to quarter 4, 2021. Your focus hospital, we're not comparing. So you can just uncheck that. And then here, it's saying he would like to exclude cases returning for chemotherapy. So under readmission flag, our default here is chemotherapy. You want to exclude cases. So we want to make sure that it's checked, right? Right. And then under add restrictions, so we're on advanced restriction. Now you would go to clinical category and then Vizient subservice line. There should be oncology, leukemia, and lymphoma. Let's look for that. So you can hotkey, right? Just by typing the first letter. And oncology, leukemia, lymphoma. Right here. No, is that it? Oh, it might be a different. No, we changed our oncology to
from the-
lines. So we'll just select this one. That's what he wanted, right? Leukemia and lymphoma. Okay, so what we can do is just select leukemia.
So I'll let everybody know what happened there. So these scenarios were written last year. And when we released our new service line versioning in September, we actually got more granular with our subservice lines. So now oncology has subservice lines for lymphoma, multiple myeloma, myeloid lymphoma. So we've gotten even more granular in our service line definitions. So apologies for that. So what we're going to do here is just select some options for subservice line.
All right, so we're going to select leukemia, right? And then hold your shift button and then select lymphoma. No, not shift, control button and select lymphoma to multi-select. So it should look like this. Everyone here yet? Okay, now let's click OK. And so now our subservice line here, oncology, lymphoma. All right, and I think first he wanted to make sure related visits only, and it looks like our readmission type there. Under readmission type, make sure you have related only. Right? Yep. Okay, so now let's run that. Because what we're going to do, we're going to run the same report, clicking on those 3 radio dials. And he wants to know the 30-day readmission rate for this one related. The 30-day readmission rate is 5.26. So that's for related. Unfortunately, you have to run 3 reports.
You could though export this to Excel, save that output in your Excel, then run the second and the third, and then merge your reports so you've got them all in one document. Even though in the tool you have to mine them separately, you can combine them in an output.
Yeah.
Okay. Why 3?
Because the scenario is asking what was the total number of cases for related, unrelated, and all.
And so you can only select one radio button at a time.
Yeah.
Right. So that population based on the standard restriction, you can only apply unrelated and run it. You can only apply related and run it.
Right
And
here.
like it's the logic of the restriction you're applying to your data query.
And what Jen was saying is you can, if you want it to be in one report, because remember, you're not going to give him 3 different reports. He won't like that. So you can export using this Excel. And then when you open that, it will look like this, right? So what I would do then is click, make a sheet here. What you can do is copy this if you like. And then paste here. And then you can put related here. You can make this pretty, and then let's run the second part. You go back here and all we have to do is change it to unrelated under readmission type. Right? And then run. Or what we can even do is we should have run it exporting to Excel from there. But looking here, our cases, readmit cases, 4 out of the 38. And so it's 10.53%. So double the related. This is unrelated now. Again, so we're gonna export to Excel, open this up. And then from here, what you can do is just copy this, go back to your Excel, and then paste it here. And this is unrelated. Right? Nope, hold on, I did not copy it right. Because it's the same. There. Oh. Why is it the same number?
The 30
Oh,
degree,
no?
that's different.
Okay,
Yeah, your case volume.
The cases, yes.
okay, sorry, I was looking at this, I'm like, it's duplicate. All right,
Your eyes are deceiving.
yes, so now let's do all. And then let's export straight to Excel because we know we're experts now, we know how it looks. And then open this. And then here again, Control C, go back to your first worksheet. And then you can say this is all, right? And then now you can see it, 3 readmit cases. So the highest now is your, of course, all. And the next is unrelated and then related. All right, questions on scenario 2?
I don't have a question on the scenario, but I have a question on the other, and I think I already know the answer, I just want to clarify. When you're running reports and you're using the tabular view, if you don't export it to Excel and you go back and you run your second one, it's gonna overwrite
Yes,
the first one, right? Okay.
unfortunately.
Okay. Just want to make sure.
All right. So those are your readmission rates for your subservice line oncology, leukemia, and lymphoma. Okay. So scenario number 3 is severe sepsis has always been your facility's top base MSDRG. So 293 and 294 for inpatient readmissions. Your leadership team would like to understand why these patients are returning and would like you to review 10 cases who had a base MSDRG of severe sepsis and understand what base MSDRG these inpatients returned with. Remember, we talked about the base MSDRG yesterday, risk methodology. And then, do you recognize any base MSDRG patterns? So let's go back here. And now, because we're doing inpatients, we are going to click readmissions, case profile reports, right here. Under the I want to look at, and we are selecting both cases in readmit pair. Remember your other selections. And then we're just gonna select 10 case profiles for now. And remember, it's not, you can only, I think yours, what's your maximum selection? Yeah, no?
1 to 50,000.
Yeah.
Any more than 250, the
You will
tool is
have
going
to
to prompt
schedule.
you to schedule it, to run in the background. You won't get an immediate output. You'll have to do what we call a schedule. And then, exactly, unless it's dollars, $50,000.
All right, so now we're back to your standard restrictions. We're only looking at related. Okay. Related only,
All, I've got.
no,
make sure
I'm
you're-
missing all, sorry, all. and then the base MSDRG of septicemia. So let's delete our, unless you refresh your report builder, then you go to advanced restrictions, right? And then base MSDRG would be under clinical category. Oops.
What about everybody else?
So sometimes it just,
Sometimes-
you just have to click off anywhere in space and it'll stop doing that refresh.
All right, so let's click on base MSDRG. All right. 293, 294. All right.
You're much better at hotkey than me. I'm afraid of hotkey because I always mistype something, and so I'm a scroller. So some people are scrollers to find their stuff. Some people are hotkey folks.
All right, so let's select the 293 and 294 base MSDRGs. Click OK. So this one, I think we have to add a, okay. I think that's good. We don't need to add anything. So let's run that. Remember, this is your case profile reports.
And in this example, we used base as an example, but you can define your populations however you want. I mean, if you want to define them by MSDRG, if you want to define them by ICD-10, if you want to define them by Vizient service line, these are just examples we're showing, but you have options of any way you want to define your multiple ways.
And I selected only 10. Yeah. Sometimes it takes a while.
Case profiles do usually take a while to generate because you're just mining all those data elements for all those.
Are you guys spinning too? Good. And we're just gonna do it in tabular, and to look at which base MSDRG, which base MSDRG patterns, we can export it to Excel and look at it that way.
Is one faster
I'm sorry?
is one faster than the other?
It would still be the same, yeah.
And again, the exercise I showed you all earlier when we were doing Q&A, sometimes the benefit of running it in tabular is you can wipe out stuff you don't want, save your layout too. But
What? Wow, it's taking a while.
anybody get results yet?
Wow.
Yeah.
Yours is the
I
same.
can
too?
tap dance. I wasn't building. I was
Okay.
actually just-
Ah. All right, well, we're gonna move on to the next scenario for now. Oh, that's,
So I think the point of that exercise would be then you're going to get those case encounters in an Excel format, and one of the data elements is base DRG. And so you can go through on that return visits and look at what the base DRG was for those return visits, and use your Excel manipulation to look for volumes, patterns.
all right. While that's loading, let's just discuss this and see if you have any questions regarding the scenario 4, which is your boss would like you to create a report that can pull the top readmit MSDRG cases with severe sepsis with a POA of Y on index, and a top readmit MSDRG cases with severe sepsis with a POA of no on index for 2 quarters. He or she would like you to focus on 7-day readmissions but also include the 30-day readmissions. Let's look here. We are still, yeah. So to do that, just X this. Yeah,
If everybody's still spinning, if you want to follow along,
just X that out, and then we'll come back to that later.
What you can also do while it's spinning is just go to like your My Tools and reopen it on the database.
Mhm.
I do that a lot.
open a new window.
Yeah.
Now I just get it out. It's spinning.
Yeah, like.
Oh, maybe there's.
Then I wonder if
Yeah, because I can't get it back up. It took me all the way back onto the homepage and now back to report builders.
I'll check in at least.
Okay,
Mine just loaded.
mine just loaded. Okay. All right. So should we move on to scenario 4 then? All right, so now what we're gonna do is click both under report patient type. And then under the I want to look at section, let's choose readmit by readmit revisit. All right, and then now we want to know which MSDRG. So let's select a bivariable of MSDRG readmit right here. And again, we're going to select 4 quarters, no, 2 quarters. You're paying attention.
Yeah.
Good. And then under advanced restrictions, hold on, standard restrictions, I think we're good here. All, and then advanced restrictions. Let's click on diagnosis. Any diagnosis. And we're going to select sepsis. So type in severe sepsis. All right, search. And these 3 codes, select all, because that's what we like. And then add selections. And then we're gonna add the POA flag, right? POA yes. He wants to know the POA yes and no. So first report, again, these are 2 reports. The first one, we're gonna select yes for the POA flag by checking the checkbox there, selecting Y, send to CDB, and let's run. We want to know which MSDRGs. You would like to focus on your, okay. So let's sort by cases first. So again, septicemia 871 is your highest MSDRG there, just by cases, right? And now we want to know the 7-day readmissions. So you can, why is it saying 7-day readmissions? Did not select. Hold on, I'm looking at my restrictions. Am I supposed to select?
It should be in your output, the 7:30 to 7:30. 7:14:30.
Yeah. It's not there.
Should we use just the regular readmission cases instead? For the report?
No, it says both readmissions. Inpatient type, both. Well, this is going to show you that you're 30-day readmit cases, but not 7-day. So we can go ahead and click on that. numerator for readmit cases, right? 871 is still the highest MSDRG.
Can you add a range removes there? That might be slightly. We'll have to change that scenario.
Yeah. All right, so let's go ahead and go back. I just X'd out my screen there, and we can go ahead and just edit this one to no. Right? You just click on that edit button, and we're back here now. All right, so let's select N for no.
You click the button.
Yeah, no. Okay, and then send to CDB. And let's run the report again.
Did you use the edit icon? Was that-
Yeah.
Yes, so that there's an edit
Edit
icon
icon.
under advanced restrictions. It'll take you back to that open window and you can change it.
So 871 earlier. So now let's select readmit rate numerator cases, sort it, the header. And then now for POA no, sepsis, your MSDRG is heart failure, 291. They're all ones, so 871 is still there and so forth. So this is what you're gonna look at. But it looks like you guys don't have a lot of readmissions there, so. Are we good with this scenario? Any questions? All right.
So scenario 5 is looking at payer type, traditional Medicare. Is that resubmission nailed been fixed? So the scenario 5 is looking at, if we're gonna look at a payer type, traditional Medicare. Do you know if those data resubmission?
That has been fixed.
Okay.
For UMC.
Cool, okay.
All right. Any other questions for scenario 4? All right, scenario 5, your leadership team has noticed an increase in readmissions in the past, and a performance improvement team was implemented to make improvements. And now they would like to see the results the team has made over the past 2 quarters. They specifically want to see results for patients 65 and older who have Medicare traditional indemnity insurance to help mimic the CMS algorithm as close as possible. What report template would you use? Anyone knows? Let's go. Let's go back to that report template. So I wonder if are you running a report now? The admission case profile report. So we're gonna use, there's a section that says CMS measures in there. Go back in there. Wow, it's really slow.
Yeah.
All right, now here we are. The second one, CMS measures, click on that. Okay. And then we're gonna click CMS readmissions. And then right here at the very bottom, as you can see, there are other diagnoses there for COPD, acute MI, heart failure, pneumonia, and our THA, THK readmits and CABG are in there as well. But we're interested in the hospital-wide readmits.
That's why I believe that's happened yet.
Okay,
So I don't. Yeah, that's happening.
all right. So click on the CMS measures and then readmissions. And then the last one is what we're going to click here, open the template. We good? Okay, click on that. Our time period. We can keep that time period. See, right now it's a different focus hospital, so let's make sure you were selecting your hospital here. Okay. Past 2 quarters. Actually, let's select quarter 3, 2022 and quarter 2, 2022. Okay, and so now look here, see those expressions we talked about yesterday? This is where it's very helpful. Applying to index, applying to readmit, and then the different letters here, as you can see. So imagine putting these all in there. Yeah. All right. But now we are going to make sure in our standard restrictions that we are include only, not standard, I'm sorry. Add restrictions here, 65 and older. And then primary payer is there, because that's what they're asking, right? Your leadership team. So let's go ahead and run that in tabular.
While that's running, just so you guys know, you can't run these reports on admin at the moment, having looked correct. Because admin, we have a payer issue that we are. But OU Medical Center and Children's, the payers.
All right, so this is your hospital-wide readmissions per CMS definitions, as close as possible. And here's your data. 30-day readmit cases, 105, and your percent readmission rate, 10.47%. It will also give you your 14-day and 7-day readmission rate. Okay. So this is for this time period. So you might want to go back here if you want to look at your baseline. Hopefully you have a baseline. Then you just have to change your time period here. Okay. And then compare it from the 2 quarters that we selected. All right, any questions on this one? All right, scenario number 6 is your ED director has noticed an increase in the number of returns to the ED within the last quarter. He or she believes the returns are occurring within the first 7 days, specifically on 1, 3, and 7 days. So he would like these numbers compared to your Vizient Q&A cohort according to your Vizient Q&A methodology. And what was your percent of return cases for each return day? And then how does it compare to your cohort? So let's go back here and select under patient type, non-inpatient. All right, and then in the report section, here are your options for the non-inpatient reports. We're interested in the returns to the ED. So let's click on that. And then here you have the option under return days. You have the option to enter 1 to 30 up to 5 numbers, but we're only interested in the 1 day, 3 day, and 7 day. So you just put in the number and then comma for each of the numbers to separate them. If I want to put 14,
Will it not work?
I'm going to try that. Probably won't. You know, just like when you put it in the advanced restriction. So we're interested in 1, 3, and 7. What's our time period? Last quarter. So let's select quarter 3, 2022. And we are going to compare, right, to our cohort. So what you can do is help me decide using hospital profiler. or if you have a custom list that you've already done. I have one already done here, and this is going to be the same as the Vizient Q&A cohort. So let me show you that, how to do that. So help me decide using hospital profiler. Click on that. Are we all here? And then profile general tab. Right here, pre-selected comparison groups. Click on the arrow and let's select Vizient quality and accountability. And then this one, Comprehensive Academic Medical Centers 2022. That's your Q&A cohort. Okay. So from here, we're going to send hospital list to CDB. First teal button. And then it should be selected here. See how it's highlighted. And then from here, you can go ahead and save the above selections as a custom list if you want to do that at this point. And then save it the name you like. Click OK if you'd like. Are we good? All right, so moving on, let's see. Oh, we want to make sure that we're clicking on the show grouped, right? Because we just want the aggregate. We're just gonna compare it with the group instead of the individual hospitals. And I don't think we need to add any standard restrictions here. Oh, look what I did. I did not refresh. Did you do the same?
Oh, that's why I was wondering.
Oh, you
Did
refreshed
something?
Okay.
I didn't know what you put down there.
I'm going to delete this restriction. Are we good?
Yeah.
It's not responding?
Oh, it is now. I already
Okay.
put it back.
Okay.
It's just being really slow.
Uh-huh.
Responsive.
So are we good here? So let's run. And you should have this report output. So let's look. For 7-day return, are we looking compared to our comparison? Not good, right? How about 3-day return? Same thing. And 1-day return, same thing. So this is something you might want to look at, right? By clicking on the case profile reports if you'd like. For the 3-day, you can click here, 7-day, you can click here, but you don't have to do that now. All right. Any questions on this? Do we have anyone here from the ED? Okay, let's move on. How's our time? We're good, right?
Yes,
Still
we're
good?
good till break is at 10:15.
All right.
And I'm pinging Lisa about performance.
Okay. So scenario number 7, you have been asked by your quality leadership team why your total revisits access days has increased significantly, and they want to understand which area or encounter type of your hospital is experiencing the most revisits. Is it observations, inpatients, or ED for the most recent calendar year? The standard restrictions are pediatrics included or excluded, why, and then break down each column and describe. And then how is the access days per 100 index encounters column calculated? And we have that formula there that we're going to show, that Jen showed you earlier. So let's go back to our, this time I'm going to refresh. Clicking report builder. And then clicking on both for our report patient type. Because for both, if you're looking at total revisits, it's only going to show in the both radio dial. And so now let's click on total revisits, access days. Okay, and what's our time period? Most recent calendar year. We're going to select these years. Focus Hospital, OU Med Center. And do we need to compare? No. And then right here, we're excluding pediatrics because to align with the Q&A methodology. All right. Then go ahead and run the report. So this will be your total revisit success days. So what you're looking at here, you have 16,000 cases for your index encounters, right? Inpatient cases, 1,500. OBS cases, no, you did not have that in that time period. And ED cases, 1,700. And then when you total these three columns, this will total your revisits, right? And now when you're looking at your revisit rate or readmission rate for your inpatients, it will be 9.6%. And then your revisit days in the OBS, again, it's 0. And then ED, 861 days. And then when you this total right here would be totaling your revisit days inpatient, OBS, and ED. This one right here. And then you have excess days of 10 days, about 10 and a half days per 100 index encounters.
Then I think my numbers don't look. I know that I probably did something right. Don't know what it is.
Well, we can we can look at here. So
And we did.
Oh, I think that's at least for me. I'm gonna have like careful with.
or we can set that as your default. Well, is that what you're gonna do using 2022?
Well, let's pause one sec. So risk won't matter for readmission reporting because we don't.
It's not risk adjusted.
So you're not, unless we're looking at the, mortality. Well, I take that back. It does matter.
Because of
It
the
does matter
revisits.
because we're in the total revisits and because the length of stay excess date. So yes, I'm sorry. That is true. So risk matters, but it's probably also likely that it's those 3 additional standard restrictions that your report type all, your CMS unplanned, and then your checkboxes. I think that's where we tend to see the differences and nuance. And I apologize. Yes, risk does matter in a total revisit excess days because of that that expected length of stay metric. But in a standard readmission report, risk wouldn't make a difference in that, to clarify.
It looks like Ronnie, we have, or I don't get why. Why not the same? That's what you have. So I
Okay.
think that's the difference. Because
Your
all the
version.
numbers are the same.
Is it only that expected value column that's different?
Yes.
Yeah.
Okay, then
Yeah.
that would be why.
Yeah.
Then it is the risk in that regard. Yes.
You're good with that, Ronnie?
It's gonna be a challenge for me.
Well, okay, so let's do that.
Remember from yesterday that default at the moment is going 2021,
Okay.
but it will be changing to 2022 here. January?
When period 0 releases. So yeah, so basically, so
So we don't have to raise that.
it'll reset the default. Yeah.
Uh-huh.
Is that mark equals exclusion?
Yeah. Yeah.
Yeah.
It's same. My brain just doesn't, I have to really give that some brain power when I think about it and when I train it. So a check means you're excluding it.
Yeah.
Yes. And so if you want to include that population, you want to uncheck. Yeah.
So in our standard, what do we do?
It's already, that's the default for your total
Yeah.
revisit success days report.
Total revisits excess days is a very hard coded report because it was designed to mimic Q&A. So a lot of that is already hard coded in there, like your check boxes, you'll see just those 3 are exclusion criteria. That's the one too, you can't choose the time frame of customizing.
Yeah,
the
right
months,
here.
You know, so it's this template is very
Yeah.
designed for you to track and trend your Q&A metric in this Q&A.
So if you're on this report type, see how the options down here are grayed out. You can't select months. It's all going to be, always going to be quarters. That's the nuance of that.
Okay, good.
Okay.
But you raised a great point. I mean, and that's why the beauty of all of you being together and doing exercises like this together, because you recognize, you know, like it's just some data governance stuff that I think, you know, right, like what risk model are we going to select? Are we going to use related or unrelated or all? Are we going to use the CMS algorithm and have a consensus about your data governance too, about how you build? So yeah.
Because we don't, if we send it for anything,
Mhm.
just gonna be full of, like,
You're right. Yeah. Yeah. All right.
And that's, you know, the distribute reports feature we talked about yesterday too. So, you know, once you kind of establish what your criteria are
you
going to be and then share that report and,
You
you know,
have the
label
power.
it as such so that you know that's the one you're going to use.
All right, our last readmission scenario. Your respiratory therapy director is interested in knowing how many patients had a base MSDRG of COPD who returned with the same base MSDRG, so related, for the most recent 3 quarters. Then he or she would like to review 10 cases if they missed something in their care. Again, this requires 2 reports. Let's go back to our report builder. Again, I'm going to refresh. The first report is going to be inpatient. Oh, it's asking me to sign in.
Were you over too long?
No, I was.
Lisa's checking. Lisa, I just said we're got about 20 folks having some slowness. She's checking with the developers on server.
Did they also ask you to sign in again?
Yes.
Yes. Oh,
That's slow there. Okay.
So even at home, I work. Yeah, and I do an alternate work with Vizient, and so even alternate work.
we,
We have a student.
Thank you for that feedback. There's a lot of tech development going on in addition to how we're processing the data. We're also moving servers to the Azure cloud, which I think is going to
yeah, it's going to help.
I'm not a technical person, so forgive me when I try to use the technical language, but you know, like servers that are, you know, cloud-based will make it a lot quicker. Yeah, thank you. Yeah.
All right, so.
I got it.
All right, let's select readmissions. And then related only, right? Our time period, 3 quarters. So let's select 3, 2, and Q1 of 2022. And no comparison. And then make sure that your readmission type is related only.
Can I pause you there?
Mhm.
I heard someone ask. So,
Oh,
so we can alphabetize the variables. It's in set my preferences, and we'll do that. I think we're going to have some extra time after the Q&A discussion, and we can go back and revisit those kinds of things. Just kind of some tips and tricks, and I'll show you how to alphabetize your variables to make life a lot easier for you when selecting those. Yeah.
All right. Thank you.
Just make sure to report it.
Oh, sure,
Oh,
sure.
okay.
We'll make sure to do that.
All right, now let's add restrictions and clinical category for our base MSDRG, right? Select that one. And we're looking at COPD. Good thing they gave us the PACE MSDRG, which is 65. Right here,
Or you can search the.
yeah.
Okay, when I did that now, where did it go? Yeah, and so then I just click OK,
Mhm.
but when I come back over here.
Oh, did you select the box next to it? So if you want to type it in, COPD right here. See,
Yeah,
Oh, there we go.
and then
I didn't do that.
and then you go like, click on.
see.
Where
Okay, so I already selected it.
It's on there. Okay.
Okay. All right, let's click OK. And you should have it at the bottom here, base MSDRG. Okay, and let's run that. Oh, okay. Sorry. Let's go back. Because right here, we're supposed to apply it to both because we're using related. We're supposed to apply it to the index and the readmit for both, right? Especially we're selecting related. And so now we're running it. All right. So here, we want to know 30-day readmit, 12.82%. And now the next one, it's asking to review 10 cases and see if we missed something in their care. Okay. So let's go back, X this out. Any questions on this? No. Okay. So now we're going to go back here and change this. Hopefully this time it will work. Readmissions case profile. Oh, that one, it's not the report patient type. Unfortunately, that one you can't
Thank you.
alphabetize. I think they said it's based on popularity. Like the patient outcomes default. Yeah. Oh, wow. This readmissions case profile report is not wanting to run today. So basically it will, there. And then both cases, make sure we're selecting both, right? And then 10 cases here. All right. Then we're gonna keep the same selections there, and let's view it in tabular.
So yeah, sorry, I aspirated on my water. I should clarify, the report types, we cannot types. Report type, but your variables can be out.
Oops. I found it. All right, so do we give up?
You went.
I just chose Osborne or to see if,
Oh, good idea.
and it didn't matter, it's still
Oh, okay.
on that. So, one.
Admissions case profile.
Now let me clarify that with Lisa, too, that that's the worst.
All right. So any questions while we're waiting for this to load? So yesterday I did not get to show you the risk model calculator. Can I show you that real quick? Okay, while we're waiting here. And let me know when yours pop up. So basically you would open that risk model calculator, right? And now I'm in the AMC. So make sure you're selecting in the Learning Center, you're selecting the correct version. So if you click on mortality risk model, so there are different outcomes here, but usually we're just interested in mortality, for example. And then right here is where you're going to select your model group. Again, not MSD or G. When you look at your case profile report, you have to look at that model group. Okay.
And that's a field that can be added to a case profile. They're not by default there. You have to go into. Yeah, let's.
Oh, I'm sorry.
Let's start it.
That's
Yeah.
what we're talking about. because
Yeah.
we can't-
So Learning Center, so let's start there. Let's walk them through Learning Center, because I even struggle with this too. So even go back a page to dashboard. And when you're in Vizient, right? This is everything Vizient, and you go to Learning Center. Learning Center is all things Vizient. So you want to find CDB for starters. So once you find CDB, it's the second header down, and you click the orange link, Access Learning Resources. So now see your blue header bar. Now we know, okay, we're in clinical database. Okay, no worries. We'll go back to your dashboard page. On the left menu bar.
Learning Center.
Learning Center, yep. And then that first section is all Vizient Learning. So you'll want to look for the clinical database section. And then there's an orange hyperlink for the clinical database. So now you're in CDB Learning and Education Center by that blue header bar. You know you're in the right spot.
Are we good? Okay. Oh, you got your case profile report now, huh?
And so all things CDB related are here, and resources that we keep referencing throughout the yesterday and today are at the bottom of the page under each of these different tabs. So these are where you're going to find your Excel workbooks and PDFs. Oh, Dorothy,
Here we are now. Can we talk about this now? Sorry, I'm just trying to use our time here. All right, so this is your case profile report. And as you can see, I selected 10, right? But I only have 7, and you'll know here, case 1 of 7. So that means you only have 7 cases in both readmit pair. Related only, right? With COPD. So that makes sense. So we only have 7 cases. And this is where you're gonna see your, if you look at the MSDRG 190, and then if you look at the patient ID 5811, your second case would be also 5811. So that's the index, the first one. This is your readmission, the second one. And I also want to show you, it's easier for me looking at case profile reports in Excel. So you export to Excel. Okay, click on that Excel icon. And when you click on that, open the Excel icon. And right here are those 7 cases. So what I usually do, if I have a lot more, I filter my headers. You know how, let me move this around here. So if you go here and click filter, and then what you can do under your patient ID, it defaults to this, but you can, for example, if you selected different quarters, if you just wanted specific discharge dates, you can filter here and so forth, and then admission status. But look at your, yes.
See that spot.
Yeah. And you can see these are two unique patients. And how do you know that? It's because of the medical record number. So this patient had 2 cases, so just one revisit, because the first one is index. The second one is the revisit. And then this means that the patient came back within 30 days, right? For 4 times. And this is where you're gonna see. Then you can look, admission status are all, yes, emergency, they all went through the ED, what are their discharge status for each encounter, and so forth. All right, any questions on this? All right, so we'll go back later to the risk model calculator. That was just a teaser. So now you know, Michelle, where the risk model calculator is.
So we'll take about a 15-minute break, start back up at 10:30.
Mhm.
We're going to cover Q&A metrics. I'm just going to do just a real high level overview of the Q&A, and then really any questions you have on the Q&A. And then what we time is go into some of those tips and tricks about alphabetizing your risk variables. We can go back to some of those report builder scenarios from yesterday if we have the time to do so. Would be good too. Any questions or thoughts? I'll just do a quick test. Folks, can you hear me okay?
Yes.
Thumbs up. Okay, great. All right. Well, welcome back, everybody. We're kind of in the home stretch here for our 2 days of some intense learning about the CDB. What we're going to spend this last hour or so on is talking more about our quality and accountability scorecard. I'm going to give a little bit of a history background, kind of how the scorecard was developed, created, and then we're going to go into those calculators, excuse me, and really look how you can use some of our tools to help you track and trend your performance as it relates to the scorecard. So with that, let's go ahead and dive right in. So just a little bit of a history lesson here. So Vizient, before we were Vizient, the clinical database actually originated over 20 years ago with a group of hospitals known as University Health Consortium. So it was a consortium of hospitals, a nonprofit group that basically said, you know, how can we consistently be successful in providing quality care? And let's be transparent with sharing data. And so it started with just a handful of hospitals that were willing to share data. We just had a big celebration because in 2022, we've now surpassed 1,000 hospitals in the database through those years. And it was really funny at that internal celebration. We had some folks that had been with Vizient before, you know, when it was UHC, and they talked about how they used to send data sets out on floppy disks to our members. Like that was how we, you know, shared and socialized data before the online platform became available. So, excuse me, just from a historical perspective, the tool has been around for quite some time, and very early on. So you can see in this timeline here in 2005, really is when that development of the scorecard started. In 2015, it became what was known as the Quality Leadership Award. In 2017, with all of the increased participation by community hospitals, we recognized the need to split out the cohorts from academic to community. And then in 18, that was even refined further. So we went from just having AMCs and community to then segmenting out what we call our complex teaching medical centers. And then again, in 19, that was refined even more. So now we have 4 major cohorts in this quality and accountability scorecard or study. Sometimes you'll hear it referred to as a study because it actually was published in quality journals as an actual study. But we now know it as a scorecard each year that our member hospitals, especially those longstanding, you know, really look forward to those results. A lot of strategic goals at a lot of our member hospitals are based around quality and accountability performance, you know, improvement. Some, you know, it's achieving top 10 status in the cohort. Others, it's, you know, 20% improvement in ranking. So just different ways that they're leveraging, using it as a strategic imperative for their organizational goals. So with that, I just want to talk a little bit about the cohort growth. So I've highlighted community and the comprehensive academic medical center because your two facilities, Edmond and OU Med Center, fall into these. Of course, Edmond being community hospital and OU Med Center being the comprehensive academic medical center. I will say for Children's Hospital, we have specialty cohorts as well. So we have oncology specialty hospital cohorts, we have pediatric specialty cohorts, and we have critical access hospital specialty cohorts. They're not included in this information. Because they're specialized, they're kind of their own separate entities, but this is in our standard quality and accountability scorecard cohorts. So you can look at that growth, from 2018 in the yellow bar to the gray bar in 2022. This was from our period 3 data. So just prior to the release of our annual scorecard, but going from 99 to 267 hospitals in the community cohort that are being benchmarked in this scorecard. And then fairly consistent in the community, comprehensive academic medical center, or what we often say CAMCs. We love our acronyms at Vizient in case you haven't already figured that one out. So now at 107, we actually between 21 and 22, we had additional academic medical centers come on board. So, again, the idea here is that you're comparing yourselves against like hospitals, right? Comprehensive academic compared to comprehensive academic. Community, as that cohort continues to grow, I know there are some eyes looking at, can we even further refine community hospitals through some, different criteria and definitions. So speaking of criteria, let's look at that top box. So this is really how we do that first line stratification of our comprehensive academic medical centers. And it's based primarily on volumes of certain procedure types. So these are hospitals that are doing at least 25 solid organ transplants a year, or at least 600 trauma service line cases, or 1,500 acute transfers in annually, and then at least 125 combined cases of neuro and CT surgery annually. So that's kind of the threshold criteria based on volumes. And they do a look back like 4 years of volume, because we know with COVID, a lot of that kind of volume fluctuated. So they really, the data science team that's responsible for creating our cohorts, creating our methodologies around our scorecard, they really look closely at that, those volume trends, and their goal is to have stability. They don't like to see hospitals bounce between cohorts. And again, we generally see that in the next section, the large specialized, where they're not necessarily meeting the thresholds that I shared above. And then community really doesn't meet any of those criteria. So they're not, generally doing at least 25 neuro or CT surgeries, and they're not meeting any of those other trauma or transfer in categories. So those are the cohort criteria. This is a breakdown. Now I'm going to show 2 different slides. So you'll notice in the top right corner here, this is the comprehensive academic medical center cohort breakdown of the metrics in the scorecard itself. So we talked, when I was doing the readmissions discussion, I talked about the effectiveness domain. That's one of the 6 domains that's considered in the Q&A scorecard. The pie chart represents all 6. You'll see safety, mortality representing 25% of the scorecard. So heavily weighted and emphasized in your patient safety and your mortality metrics, with effectiveness being the next largest at 20%. And again, that's looking at those metrics around readmissions, as well as some other like returns to ED for those procedures. Like we showed you those arthroscopy, there's some metrics in there for colonoscopy. We isolated a few high volume procedures that we look at returns. So that's included in the effectiveness domain. Like I talked about yesterday, patient centeredness is acquiring your HCAHPS data from your patient experience vendors and pulling that in at the facility level. That's 15% of your overall score. Efficiency is 10%. Efficiency domain looks at things like your direct cost metrics, so indices for your observed to expected direct cost, as well as length of stay metrics. And then the smallest bucket is our equity bucket. That's looking at several different metrics stratified by race, socioeconomic status, male versus female, gender criteria in that as well. Over on the right-hand side is basically all of the different metrics within those domains. So within each weighted domain, you have individual metrics. Again, safety, we're pulling in some of the ARC PSIs, not all of them. We're only looking currently at 3, 6, 9, 11, and 13. We are, I should also have pointed out that quality and accountability is also driven by our steering committee, which is made up by member hospitals. So we have member hospital participation in helping us decide the metrics, the metric criteria. So this isn't just necessarily Vizient saying we think this is what is best. This is based on member feedback too. So that's how we're getting those PSIs that are included. Again, mortality, we're looking at that O to E or index ratio for mortality. And then, you can see the others listed in there as well. Now, for your admin facility in the community hospital, the domains are the same. So we have the same weighting in the domains. I'm going to go back 1 minute here to the comprehensive academic medical center. And what I want to point out is, like, for example, under effectiveness, there are 13 different service lines that are evaluated. So in our comprehensive academic medical center for the Q&A, we're looking at a larger number of service lines for the overall scorecard. But you'll notice when I move to the community hospital cohort, while the pie chart is the same and the distributions are the same, for example, under effectiveness, we're only looking at 6 service lines here. So about half the number of service lines. And this would be expected, right? Again, in a community setting, we're not likely seeing organ transplant. We're not likely seeing trauma. So this is why, we've got the differences between the cohorts in the number of Q&A service lines. This is an example of what the scorecard itself looks like. So this is just from a fictitious hospital we use in our demo database. So this is the 2021 example, but kind of moving top to bottom on the page. So you'll see over here, there's a star rating. This is not to be confused with CMS. This is a Vizient star rating. So based on the distribution of your ranking within your cohort, those that are in the top percentage, receive a 5-star all the way down. So we have 5-star and so on. There's a distribution that you'll be able to see within the scorecard itself too. Hospitals can also see their overall rank. So again, all the different domain weights and scores roll up into one overall score, which is over here. So this hospital has a 53.33% out of 100, and their overall rank is 48. Within this circle here, we can see all those different domains, and it's color coded based on performance. So green, obviously good, is kind of how we like to interpret that. So when you're performing in relation to your cohort positively, you'll see items in green, and then those where there's opportunity for the facility and the domains are in red. And then this color coding, again, you can see the total number in this demo example. Put my cheaters on here. I think it's 101. Yeah, 101 total hospitals that we're seeing, evaluated. So this hospital was 48th ranked out of 101 hospitals. And then further down in this scorecard, you'll see each of those domains broken out. You'll see performance by each of the service line metrics within the domain. We also do announce after our annual summit meeting in the fall, which is usually in the September timeframe. We usually announce, we do announce, not usually, we announce our top winners, and those folks are recognized. And then we also publish this in the scorecard. So it's available transparently for everybody to see those top performers. So that's what I just kind of wanted to cover from an overview. What I'd like to do now actually is I'm going to go into some of our tools that you have available within the clinical database to, help you track and trend your performance as it relates to the quality and accountability scorecard. So bear with me 1 sec. All right, so where I'm at now, I'm back in the CDB, and you'll see that I'm over here on the Report Express tab. And again, this may be familiar to you if you've pulled any of our other reports. I know in training, we talk and show you our vitals and performance, our quality and safety management report, which is, as it would indicate, a lot of your patient safety metrics, your clinical outcomes reports. So those all live over here under this management reports tab. Everything related to Q&A kind of has its own section. So I'm over here on the right side now under Q&A. You'll see the 4 cohorts all have their available scorecards. Mine might look slightly different than yours. Again, being a Vizient employee, I have access to kind of pretty much everything. So It might, vary slightly what you're seeing here, but a couple resources I'd like to point out. This is one difference in, most things are in our learning center as far as resources. As it comes to Q&A, you'll find most documentation here in this section. So we have a PDF on our methodology. So this is going to get really granular. It's a 68-page document, but it tells you how every one of those metrics in the scorecard is derived. It talks about numerators and denominators and exclusion criteria. So really, really detailed information about the methodology for those metrics that are considered in the scorecard. Additionally, this next option that I'm showing here is an Excel workbook. And this is what we call our Q&A period calculator. And so quarterly, what we do is we release this interactive Excel document that allows you to see your performance as it stands in the current quarter performance period. And then it's an interactive calculator in that it allows you to track and trend and play some what if scenarios. And I'm going to open one up and we'll talk through that a little bit. And then there's a nice document too that has some FAQs and instructions on how to use that macro enabled workbook. So I think that's another nice resource to point out that's helpful. And then also this Excel document here is actually all the different cohorts. So if we opened that Excel document, you'd be able to say, I want to see all the hospitals that are in the community. I want to see all the hospitals that are in complex care cohort or the comprehensive academic medical center cohort. So another nice document, and that gets updated, as those cohorts change. So any questions at all about some of these resources? Have you all been in here? Have you seen this?
Yeah, I think probably, I don't know if that's necessarily this group. The calculator has been one that various people have been coming into.
Okay.
But there's been so I think
Going through it, sure, absolutely, you bet. And then, as I mentioned, then those the oncology, the pediatrics, and the critical access specialties are all listed here as well. I will say that oncology, peds, and critical access are currently still what we call informational only. So we're not providing that overall ranking. These were fairly newly introduced prior to COVID. And then the intent was to eventually have those scored and ranked like we do our standard cohorts. And then, due to COVID and everything happening, we've really delayed that. So there's still what we consider informational only. So while your hospital will see an overall score, we're not doing the overall ranking in those cohorts as of yet.
When Joe came out, before it came out, we just looked into why we didn't have a pediatric
Calculator. Okay. Let me put that in my notes. So.
And if you're following along on the screen, just keep note too, that on the top left-hand corner, your default, it's going to default to the OU Children's. And OU Children's, we don't have a pediatric scorecard at the moment, and so your Q&A won't open up either. Edmund will open the Q&A, and OU Medical Center will. You might want to use it. OU Medical Center.
I'll plan to do that. Yep. So again, I'm demoing here. So again, as a Vizient employee, I have access to everything. What Tennille was just explaining is it defaults because they're alphabetical is how they're ordered in this section. So that's why children's comes up first as the default. So if you are over here trying to open this stuff, you will want to make sure that you select OU Med Center or Edmund, to be able to look at these. And I've already pre-opened the calculators, so I have those actually open in the Excel document. Should I go ahead and dive into the calculators now? You think that'd be good? Okay, so I'm going to go ahead and open, let's go ahead and look at OU Med Centers. Again, this is an interactive macro-enabled Excel. So I've already clicked the button that says Enable Content. When you open it for the first time, regardless, every time you come back into Report Express and open this document, you have to enable content. That's how you get the calculators functionality to work.
If you don't have QI macros, is it going to work?
That's probably a good question for your internal IT folks. If there's some firewall, yeah.
It's not. It's just
Okay.
not. Okay, thank you.
Okay, thank you. I'm again.
There may be
No.
keys that are disabled.
We will do a
But-
block, say block
Yeah.
content, that person's document has been disabled by your.
But it will still go through and do some stuff.
Okay. Okay. So, So the other thing I want to point out, I'm going to just minimize this and go back here to the Report Express section. Again, I like to make everything larger. You will notice there are drop-down menus, okay? So what I've opened is the actual ending calculator for 2022 for OU Med Center. But you'll see, as I talked about, there's all these quarterly releases. So we have something we call a period zero calculator. That's what's going to be released here in the next couple of weeks. This is basically your baseline kind of starting performance. It takes the metric values that you had in your annual performance last year, and it applies our new methodology. So every year, just like our risk methodology, Vizient updates our methodology with some of the metrics and also applies the new risk. So it's basically saying, okay, here's how you performed last year annually from an annual perspective in these metrics values. And then we're now applying that new methodology to see how that plays out in your performance, right? It kind of levels the playing field, if you will, so that everybody is seeing from a baseline perspective with the new methodology applied. So that's what period zero will be. Period one will then be, your actual first quarter of performance. The other thing I should tell you is that the Q&A scorecard is a mid-year cycle. We start with July 1 data and goes through June 30 data. So for the upcoming scorecard that's going to be released next year in 2022,